Begin with cardiovascular system. So first thing is embryology. Heart starts to beat at fourth week, and it also is the first functional organ formed in an embryo. And cardiac looping also begins in the fourth week. If there is any defect either to the left or right of dynein, that is called as dextrocardia, that is heart is on the right side instead of left side. This is seen in cartilaginous syndrome. Next, coming to how the atrial chamber will form, let us see atrial septum. So first thing is the septum primum grows towards the endocardial cushion and it forms a gap here. You can see here, this is called as ostium primum. Next, what happens is even the upper part will degenerate and it will form the ostium secundum, so that there is a shunt between the right side of the atrium to the left side before the birth, because there is mixing of blood. You know that in a fetus the lungs don't work, so there will be shifting of blood from the right side to the left side, and from there it will go into the aorta. Okay. And next, what happens is the septum secundum tries to grow and close this ostium secundum. Okay, and in the process of this growth of septum secundum, what happens is the foramen ovale forms like this. And finally, after the birth, as the left atrial pressure rises, this septum primum and septum secundum, both of them will finally close the septum, and you can see the closing of septum, and this is closure of foramen ovale. Because of this closure, it forms the atrial septum, which is dividing the right atrium from the left atrium. But sometimes there is an opening even after the birth, that is called patent foramen ovale. This is because of failure of septum primum and septum secundum closure. And because of this, there is a paradoxical emboli, that is sometimes the emboli from the right atrium can pass to the left atrium and enter the systemic circuit. So this is called as paradoxical emboli, and it is seen in atrial septal defect. Now coming to heart morphogenesis. So here we'll see about ventricles now, how the ventricle septum forms. So as we know, ventricle have the muscular septum and membranous septum. The muscular septum is you can see this is a muscular septum, and here it forms a foramen called interventricular foramen. Later what happens is the iotico-pulmonary septum forms, and this septum will fuse together and form a membranous interventricular septum. So this membranous interventricular septum, it closes the interventricular foramen. You can see clearly in this diagram. Here the interventricular foramen is, but here it is closed because of membranous interventricular septum. So both the membranous and muscular interventricular septum form a ventricular septum. So ventricular septal defect is what? If this septum is not formed, especially it is a most common congenital anomaly which involves the membranous septum mostly. Okay. Now coming to outflow tract formation, how the outflow tracts, that is the pulmonary artery and the aorta form, let us know. Actually the neural crest cells, they migrate to the truncal and bulbar ridges and they fuse to form the iotico-pulmonary septum, that is either ascending aorta or pulmonary trunk. If there are any abnormalities, what happens? Sometimes there is transposition of great arteries. That is, a pulmonary artery will be coming to the right side of the heart, and pulmonary artery will coming to the left side, and aorta to the right side. So it's a opposite side. And etiology of fallot, you'll have stenosis of pulmonary artery, and you'll have overriding aorta there. That is a defect. And in persistent truncus arteriosus, actually, this iotico-pulmonary septum will not divide, so that both of them will remain same as a single trunk. Now coming to valve development, actually we have four valves, that is aortic and pulmonary valves, which are derived from endocardial cushion outflow tracts, whereas the mitral and tricuspid valve are formed from the atrioventricular canal. Of course, those are also formed by endocardial cushions. So the valves are formed by endocardial cushions. Okay, that is important. So valvular anomalies may be either stenotic, if the valve is closed, that is stenotic. Regurgitant, that is the valve is allowing backward flow. It is atretic, means it is completely absent. Okay, atresia means it is absent, or it is displaced. Like in Epstein's anomaly, the right side valve is displaced, that is the tricuspid valve is somewhat lower and displaced. Okay, so all these conditions we have seen in the valves. Now coming to aortic arch derivatives. So actually aortic arch, they develop into different arterial system. Let us see. The first aortic arch is a part of maxillary. How to remember this? The first arch is maximum. Okay, maxillary artery, and this maxillary artery is in turn a branch of external carotid artery. So you can see here, this is the external carotid artery. Next, coming to second one is the stapedial artery. Second, stapedial. S for S, like that you can remember. Next, third one is common carotid artery. How to remember this? This is C is the third letter of alphabet, so it is C. Okay, carotid, and it is also third one is also related to proximal part of internal carotid artery. You can see here internal carotid artery. So common carotid and proximal part of internal carotid are related to third one. So third is for carotid, two is for stapedial, one is for maximal, that is maxillary. Fourth one is on the left side it is aortic arch, and on the right side it is proximal part of right subclavian artery. So fourth arch for four limbs, that is systemic. So left side aortic arch, right side proximal part of right subclavian artery. Sixth one is for pulmonary, six for pulmonary. Okay, like that you can remember proximal part of pulmonary arteries on left only, ductus arteriosus. Sixth arch is equal to pulmonary, and pulmonary to systemic shunt. Okay, even ductus arteriosus is related to the sixth arch. From sixth arch it will derive. Actually, you know what is ductus arteriosus? Actually, it is a shunt. We'll discuss about this later in the later part. Ductus arteriosus is actually pulmonary to systemic shunt. So let me show this here. You can see here this is a pulmonary artery. So from the pulmonary artery the blood is flowing into aorta directly, because in the in the fetus stage lungs are not developed well. So from the right ventricle blood will go directly into pulmonary artery, from there to aorta by means of the shunt ductus arteriosus, that is pulmonary to systemic shunt. Now let us discuss about the heart embryology, like what are the structures which are derived from what. So from truncus arteriosus, in this diagram if you see clearly, this is the truncus arteriosus. From this ascending aorta will be forming on left side, pulmonary trunk will be forming on right side. Next, coming to bulbus cordis. From bulbus cordis you get smooth outflow part of left and right ventricles. So you can see right ventricle, left ventricle, right? So their outflow parts here, this part, okay, those are formed by bulbus cordis. Next, coming to primitive ventricle. So primitive ventricle is nothing but the trabeculated part of left and right ventricle. Trabeculated means somewhat rough part. Rough parts are formed by primitive ventricle. Primitive atrium forms a trabeculated part of left and right atria. So primitive, whenever you see the word primitive, they form the trabeculated part of their respective name. If primitive ventricle, they form trabeculated part of ventricle. Primitive atrium, they form trabeculated part of atrium. Next, coming to left horn of sinus venosus. So here you can see the sinus venosus. So left horn of sinus venosus form the coronary sinus, and the right horn of sinus venosus form the smooth part of right atrium, that is sinus venarum. Okay, sinus venarum is formed by right horn. Next, endocardial cushion. It forms atrial septum, membranous interventricular septum, before we have seen it, right, and also AV and semilunar valves. Next, common defects in endocardial cushion can be seen in Down syndrome. Next, coming to right common cardinal vein and right anterior cardinal vein. Okay, so these veins form the superior vena cava, whereas posterior cardinal, subcardinal and supracardinal veins form the inferior vena cava. Primitive pulmonary vein form the smooth part of left atrium. Okay, whenever you say primitive, actually I said remember trabeculated part, but primitive pulmonary vein forms a smooth part of left atrium. This is a like exceptional thing you need to remember. So these are all the embryonic structure, and this to which they give rise to, you can see here. Now we'll discuss about fetal circulation and fetal postnatal derivatives. Now let us discuss the fetal circulation. So fetal circulation, one thing you need to remember is that here the umbilical vein carries oxygenated blood. So here in the umbilical vein there is a saturation of oxygen of about 30 milligrams of mercury, and it is 80% saturated with oxygen. Okay, whereas umbilical arteries have low oxygen, so it is reverse actually in adults if you see. Now coming to the three important shunts which we need to discuss in fetal circulation. So first let us understand this process. First, from the placenta, the umbilical vein which carrying oxygenated blood, it is coming, you can see the umbilical vein is passing oxygenated blood, whereas it is bypassing here without going into the liver directly. It is going into inferior vena cava by means of a ductus venosus. Okay, so this ductus venosus carries oxygenated blood to the liver, and from the liver it will come to the right atrium. From the right atrium it will go by means of fossa ovalis, or sorry, foramen ovale, which is called as foramen ovale in fetus, right? So from right atrium to foramen ovale to left atrium to left ventricle, from left ventricle to aorta, it will go directly like this. Whereas some of the deoxygenated blood which is coming from superior vena cava, that deoxygenated blood goes to right atrium to right ventricle, from right ventricle to pulmonary artery, from pulmonary artery it will go to ductus arteriosus. So here you should get one doubt, that we always know that left side have more because of systemic circulation, it have more pressure, so that if even ductus arteriosus is open, the blood should be coming from the aorta side to pulmonary artery side. But in fetus it is reversed, because in fetus there are no lungs. As there are no lungs, there is more pulmonary vascular resistance. So now the pulmonary vascular resistance is higher than the aortic blood pressure. So now the blood will be forcing towards the ductus arteriosus from the pulmonary artery to the aorta. So from there systemic blood grows. So you can see here there is a mixed blood, that is from the superior vena cava you are getting deoxygenated blood, from the mother you are getting oxygenated blood. Oxygenated blood is directly going into aorta, whereas deoxygenated blood by means of ductus arteriosus mixing and going throughout body of a fetus. Okay, after that finally again it will come back by means of umbilical arteries. Now they carry the deoxygenated blood, and again the placenta will filter this blood, give oxygenated blood. So this process cycle continues. So this is a fetal circulation. So one thing you need to know, important thing, is that NSAIDs are like indomethacin, ibuprofen, acetaminophen, all this are used to close the patent ductus arteriosus. Sometimes even after the birth, if this is open, then it causes some problems, because even after birth if it is open, it will cause deoxygenated like mixed blood. So to prevent that, we can use these drugs to close it. So how to remember? Endomethacin ends the patent ductus arteriosus. Prostaglandins E1 and E2 keep the patent ductus arteriosus open. Okay, that is important. E1 and E2 keep the patent ductus arteriosus open. In IVC there is more oxygen saturation in fetus, because IVC is receiving directly the oxygenated blood from umbilical vein. So IVC have more oxygen saturation in fetus. Okay, so these are the points we need to remember. Now coming to the fetal postnatal derivatives. So ductus arteriosus is called ligamentum arteriosum after birth. It is present near left recurrent laryngeal nerve. Ductus venosus is called ligamentum venosum. Foramen ovale called fossa ovalis. Lentois, that is urachus, is called median umbilical ligament. Actually urachus is a part of a lentois which is situated between bladder and umbilicus. Next, umbilical arteries forms medial umbilical. So umbilical medial, umbilical ligament. Lentois median. Okay. Next, umbilical vein forms ligamentum teres hepatis, that is also called round ligament. It is contained within falciform ligaments now in adults. Okay, so this is fetal circulation. Let us begin with cardiovascular anatomy. So the most posterior part of the heart is left atrium, and the most anterior part of the heart is right ventricle. So whenever there is any problem in the left atrium, it will, as you can see, very nearer to esophagus, so it will compress the esophagus and cause dysphagia, and it can also compress the left recurrent laryngeal nerve, causing which is a branch of vagus nerve, causing hoarseness, and that is called as Ortner syndrome. Next, coming to right ventricle, as I said, it's the most anterior part. You can see here, this is the right ventricle, and this is most commonly injured in trauma because it's most anteriorly present. And left ventricle is like about 2/3. It occupies more space when compared with right ventricle. It occupies only 1/3 space on the inferior diaphragmatic surface. So on an X-ray, if you take like this, these are the regions of heart. You can see this is the superior vena cava. This is the azygous vein. This is the inferior vena cava, right atrium, right ventricle, left ventricle, and here comes the descending aorta. This is the pulmonary artery, and this is the aortic knob. So this is how a heart represents in an X-ray. And here also you can see all the chambers of the heart. This is the aorta. Now coming to pericardium. So pericardium is actually having three types of layers. First one is the fibrous pericardium and the next one is serous pericardium. Serous pericardium in turn is divided into parietal pericardium and visceral pericardium, also called as epicardium. In between the parietal pericardium and visceral pericardium there is a fluid or sac which is filled with the fluid that is called as pericardial fluid, and that space is called pericardial space. So these are the layers of pericardium. One thing we need to remember is that whenever there is pericardium pain, that is referring to left side of our neck, left side of our arms, left side of the shoulder, sometimes even on the both sides of the shoulder the pain may get referred, especially the pericardium is innervated by phrenic nerve. Okay. And next thing is on ECG, if you see pericarditis or pericardium problem, that will show PR depression, ST elevation and T wave inversion. This is very important to remember. And the treatment for pericarditis is colchicine, NSAIDs and steroids. Actually in the name you can understand pericarditis means inflammation. So as there is inflammation, there will be leukocytosis, that is white blood cells will be increased. Actually this pain you can differentiate it from chest pain or like angina by, actually if the pericarditis person is lying down then the pain will worsen, if they are moving forward then their pain will relieve. So like this you can differentiate pericarditis from other heart diseases. So if lying down pain will worsen, if moving forward pain will relieve. And here the ESR, erythrocyte sedimentation rate, also will increase. Now coming to coronary blood supply. So for that you can understand this diagram. The main blood supply of the heart is by left anterior descending artery. So you can see here this supplies mainly anterior 2/3 of interventricular septum, and also it supplies the anterior lateral papillary muscle. So anterior and lateral part of papillary muscle is supplied, and anterior surface of left ventricle most commonly supplied by this, and the most common occluded artery is left anterior descending artery. Next coming to PDA. PDA is posterior descending artery, and this PDA is supplying posterior 1/3 of interventricular septum. So anterior 2/3 of interventricular septum by LAD, posterior 1/3 of interventricular septum by PDA, and also the posterior 2/3 walls of ventricles and posterior medial papillary muscle. Posterior medial papillary muscle is supplied by PDA. Next coming to RCA. RCA is right coronary artery. You can see this one is the right coronary artery, supplies the AV node, because AV node is located in the interatrial septum, so it is nearer to this, and also it supplies the SA node. SA node is actually in the right atrial wall. Here somewhere SA node will be. So the right coronary artery supplies the SA node and AV node. If there is any infarct, it may cause nodal dysfunction, that is bradycardia or heart block, because SA and AV node are used to create an impulse. So when they are blocked, there will be nodal dysfunction, bradycardia or heart block. So right or acute marginal artery supplies the right ventricle, this one. Now coming to dominance, the important topic here, that is the right dominant circulation is most common in human beings. So what is this right dominant circulation means? We are talking about this posterior descending artery from which it arises, that is called as dominant circulation. If the posterior descending artery is arising from the right coronary artery, then we call right dominant circulation. This is 90%. Whereas if the posterior descending artery is arising from left circumflex artery, actually left circumflex artery is this one, it supplies the lateral wall of the heart. So if this left circumflex artery will give rise to the PDA, then it is called left dominant circulation, but it is only 10%. The most common one is right dominant circulation. There is also sometimes co-dominant circulation, that is both the PDA is arising from both left lateral coronary LCX, that is left circumflex artery. If it is coming from both left circumflex artery and also right coronary artery, then this is called as co-dominant circulation. And one more thing, the coronary blood flow to the left ventricle and interventricular septum peaks in early diastole. This is a very important statement. In the diastole, there will be more blood flow to the heart. Next coming to coronary sinus. Coronary sinus runs in left atrioventricular groove and drains into right atrium. So this part is called coronary sinus. Here it runs in left atrioventricular groove and it drains into the right atrium. So next thing is occlusion. So the most common occluded vessel in coronary arteries is left anterior descending. Next comes the right coronary artery. Next comes the left circumflex artery. And as we discuss about the papillary muscles, that is the anterior lateral and posterior medial. You know that anterior lateral papillary muscle supplied by the LAD and posterior medial supplied by the PDA. So this anterior lateral papillary muscle have dual supply, that is from left anterior descending and also from left circumflex artery, that is towards this side, which is supplying lateral wall of heart. So both of this are supplying the anterior lateral papillary muscle, and even the posterior medial papillary muscle is having a supply from right coronary artery and also left circumflex artery. Whenever there is any damage to the posterior medial papillary muscle, it will lead to severe mitral regurgitation and also it may cause acute heart failure. Now let us start the physiology part of cardiovascular system. So first we need to understand the important terms here, that is end diastolic volume and end systolic volume. So end diastolic, in the name itself you can see after diastole means after completion of filling. So filling is completed and now it is about to contract, that is called as end diastolic volume. And end systolic volume, in the name you can see after the systole means the emptying is completed and now the relaxation is beginning, that is nothing but now the diastole is going to begin. This phase is called end systolic volume. Now let us start to see the cardiac output variables. So the first thing is stroke volume. So stroke volume is mainly dependent on cap. You can remember this with mnemonic cap, that is it is dependent on contractility, it is dependent on afterload and also on the preload. Okay, so stroke volume increase with contractility. You can clearly understand if there is more contractility of heart, more stroke volume. Like when you are in anxiety, whenever you do exercise, there will be more stroke volume. And increase in preload, of course if there is more filling of blood, then there will be more stroke volume, because more blood is coming, more we will pump it out, right? So more preload, more stroke volume. This is seen in early pregnancy. In early pregnancy there is more preload, so there will be more stroke volume. Next, decrease afterload. Decrease afterload will lead to increased stroke volume, of course, because afterload is like an opposite pressure. It is a you can remember it as like a obstructing or systemic pressure. Actually afterload is equal to mean arterial pressure. So the mean arterial or systemic pressure is high. It is very hard for the heart to pump against that mean arterial pressure. So when there is low afterload, there will be more stroke volume. So that we need to understand. So a failing heart always has low stroke volume, that is either systolic or diastolic dysfunction. Okay, because failing heart means heart is now not able to pump, that is it is having low stroke volume. Now coming to contract, let's continue with contractility. So contractility and stroke volume both increase with activation of catecholamine via beta 1 receptor. So actually what happens here is there is activated protein kinase A, and this activated protein kinase A lead to calcium channel phosphorylation, and that will lead to increase of entry of calcium. So this will lead to calcium induced calcium release. That is because of calcium only there is calcium release from the sarcoplasmic reticulum. So that will lead to rise in intracellular calcium. As intracellular calcium is rise, extracellular sodium will decrease, because sodium and calcium are exchanged, right? So decrease in extracellular sodium and increase in intracellular calcium. So because there is decreased activity of sodium calcium exchanger. Even digoxin does the same thing, that is it blocks the sodium potassium pump. As the sodium and potassium pump is blocked, intracellular there will be more sodium. You can understand this because sodium and potassium pump what it does is it takes the sodium from inside and puts out, and it increases potassium. But here as the sodium and potassium pump is failed, there is more sodium inside, and this will lead to decreased sodium and calcium exchange activity as there is more sodium inside the cell. So because of this, even the calcium will be not going out of the cell, and that will lead to rise in intracellular calcium. So because of all this process, finally the contractility is increased. Whereas contractility is decreased with beta 1 blockade because cyclic AMP is decreased, and in heart failure with systolic dysfunction, you can understand if there is no systole, then there will be no contractility, and even acidosis, hypoxia, hypercapnia, non-dihydropyridine calcium channel blockers, especially non-dihydropyridine, dihydropyridine, non-dihydropyridine. Calcium channel blockers also decrease contractility. So this is about contractility. Now coming to preload. Actually, what is preload? It is approximated by end diastolic volume. So you know what is end diastolic volume? That is after diastole. After diastole means filling is completed and now it is ready to contract, right? So that is related to preload. It is depending mainly on venous tone and circulatory blood volume. For example, if there is vasodilation, there will be decreased preload because vasodilation means more blood is not coming. If there is vasoconstriction, there is more blood which is coming into the heart, so that it is ready to contract now. Okay, so slow heart rate, whenever there is slow heart rate, there will be more preload because of vasoconstrictions, which is activated by alpha-1 receptors, that is sympathetic nervous system. So sympathetic nervous system will lead to vasoconstriction and vasoconstriction will lead to increased preload. Now coming to afterload. Afterload is nothing but the obstructing outflow. Whenever there is more obstruction, that is more afterload, like that you can remember. Actually, afterload is approximated by mean arterial pressure. So when there is more mean arterial pressure, there is more wall tension according to Laplace law. That is nothing but more pressure, that is more afterload. So in this case, the heart is not able to pump blood because there is more systemic resistance. So it will compensate it by thickening the cell wall of the heart. So that is nothing but hypertrophy. So there is hypertrophy in order to decrease the wall stress whenever there is more afterload. So arterial vasodilation decrease the afterload, of course. Whenever there is vasoconstriction, there is more afterload. Whenever there is vasodilation, now it is very free for the heart to pump the blood, so there is decreased afterload. ACE inhibitors and ARBs, that is angiotensin receptor blockers, both decrease preload and afterload. You can understand because they directly inhibit the angiotensin, so there will be no sodium and water retention, so that will decrease the preload and afterload. Whereas chronic hypertension will increase the mean arterial pressure, so you can understand there is more mean arterial pressure, so the left ventricle will undergo hypertrophy to compensate that. Now coming to cardiac oxygen demand, that is myocardial oxygen demand is increased by increase in contractility, of course, because now heart need to do more contraction work, so it need more oxygen, and when there is more afterload, also heart need to pump against that systemic pressure, so also it requires more oxygen. And whenever there is more heart rate, more oxygen is required. Whenever there is increase in diameter of ventricle, then also more oxygen is required. So coronary sinus actually contains most deoxygenated blood in the body. So the most deoxygenated blood in the body is present in coronary sinus. If you remember the coronary sinus, it runs in the left atrioventricular group and it drains directly into the right atrium. Why right atrium? Because you know in right atrium there is deoxygenated blood. So here we need to discuss about the wall tension. The wall tension follows the Laplace law, that is the wall tension is equal to pressure into radius. Wall stress is directly proportional to pressure into radius by 2 into wall thickness. So this is about cardiovascular physiology first part. Now we'll go into cardiac output equivalents. So cardiac output equivalents are like stroke volume, ejection fraction, cardiac output, pulse pressure, mean arterial pressure. Let us discuss one by one. These are like formulas. Stroke volume is equal to end diastolic volume minus end systolic volume. Okay, and ejection fraction is stroke volume by end diastolic volume. So again, you know, stroke volume is nothing but end diastolic volume minus end systolic volume by end diastolic volume. So ejection fraction is nothing but it is the index of ventricular contractility. It is decrease in systolic heart failure because now the blood is unable to pump, so there will be low ejection fraction. Usually it is normal in diastolic. Diastolic is nothing but filling, right? When the heart is filling, ejection fraction will be normal only, but when there is systolic heart failure, then it will affect the ejection fraction. Now coming to the cardiac output is equal to stroke volume into heart rate. Heart rate increases in the case of sympathetic nervous system because it increases the heart rate, and heart rate is decreased by beta blockers and calcium blockers. We need to not confuse for the heart rate and the SA nodes, AV node, those are nodes and this is heart rate. Now one more thing is, in early stages of exercise, cardiac output is maintained by increasing heart rate and stroke volume. So when you are starting to do exercise, at that time both your heart rate and stroke volume are increased. In later stages, what happens is cardiac output is maintained by only increase in heart rate, but the stroke volume remains plateau. So in the starting, what happens is there is more blood supplied to all of your body in the starting of exercise because there is more stroke volume. But later what happens, only your heart starts to beat more rapidly, but the stroke volume is peak. The blood is maintained normally equal parts in all parts of your body. Now coming to Fick principle says that cardiac output is equal to rate of oxygen consumption by arterial oxygen content minus venous oxygen content. And the diastole is shortened with increased heart rate. How to understand this is because your heart is pumping more rapidly. As your heart is pumping more rapidly, there is no time for filling. So as there is no time for filling, the diastolic filling time will decrease and even the stroke volume will decrease, and that in turn will lead to decrease in cardiac output. So now coming to pulse pressure. Pulse pressure is actually directly proportional to stroke volume. Pulse pressure is systolic blood pressure minus diastolic blood pressure. So one more thing you need to remember, systolic blood pressure is nothing but it is related to the stroke volume. Diastolic blood pressure is related to the total peripheral resistance. Okay, total peripheral resistance is nothing but the systemic vascular resistance that is related to diastolic blood pressure. Systolic blood pressure is related to a stroke volume. So you can see pulse pressure directly proportional to stroke volume, inversely proportional to arterial compliance, that is nothing but total peripheral resistance. So pulse pressure is increased in hyperthyroidism because in hyperthyroidism all metabolic functions are increased, so even pulse pressure is increased. And in aortic regurgitation, because more blood is coming back, that means stroke volume will increase whenever there is regurgitation, so that will in turn lead to increased pulse pressure. And whenever there is aortic stiffening because of more pressure, isolated systolic hypertension and obstructive sleep apnea where sympathetic tone is increased, and even in anemia, because in anemia there is low blood in our body, so our heart compensates it by increasing more cardiac output, more stroke volume. So because of that there will be increase in pulse pressure. And even in exercise, as we discussed in the beginning of exercise, stroke volume will increase, so pulse pressure will also increase. And pulse pressure will decrease in aortic stenosis because there is a stenosis in aorta, so there will be decreased stroke volume, so decreased pulse pressure. And in cardiogenic shock also, as the blood is lost, there will be decreased cardiogenic means heart is unable to pump there, so there is a decreased stroke volume, decreased pulse pressure. And in cardiac tamponade also there will be restriction of stroke volume, right, because blood is accumulating around the heart, so that will also decrease pulse pressure. In advanced heart failure, all these conditions, this decrease pulse pressure. So this is an important physiology part we need to understand. Now coming to mean arterial pressure. So as I said, mean arterial pressure is nothing but related to a afterload. So mean arterial pressure is equal to cardiac output into total peripheral resistance. Or you can say this as diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. Now let us try to understand the Starling curves. So Starling curves is a force of contraction which is proportional to end diastolic length, or you can say preload. So how much your heart is contracted is directly proportional to preload, because if more blood is coming, more the heart contracts, right? So you can see increase in contractility here. Whenever there is more contractility, there is less total peripheral resistance, because if there is less resistance, more contractility, right? And this is achieved by catecholamines, positive inotropes like dobutamine, milrinone, digoxin. All this will lead to increased contractility of heart. Whereas contractility is decreased with loss of function of myocardium, like in myocardial infarction, by beta blockers, non-dihydropyridine calcium channel blockers, heart failure. In all these conditions, contractility will decrease. As contractility is decreased, total peripheral resistance will increase. So this we need to understand in Starling curve. Here you can see in running contractility will increase, because in the starting of exercise both your heart rate and stroke volume will increase, right? So contractility will increase, total peripheral resistance will decrease. Whereas in rest you can see somewhat it is lower. In heart failure and positive inotrope, you can see how the curve is. In myocardial contractility, this is a myocardial contractility. In heart failure, you can see contractility is decreased and total peripheral resistance is increased. So this is the Starling curve. And one more thing you can observe here is eccentric hypertrophy, concentric. So eccentric hypertrophy is nothing but systolic heart failure, that is heart is not able to pump. So in this case the blood remains in the heart itself, so the left ventricle size will increase but the wall will decrease. Only the size will decrease, and that will lead to dilation of the heart, and this is also called as dilated hypertrophy of the heart. Here there is volume overload. So you can see this condition in aortic regurgitation, because blood is coming in back up, like blood is coming back and it is getting involving the left ventricle, and that is overfilling. and that is leading to increased left ventricular size and thinning of wall. So that is leading to dilation, hypertrophy. Whereas concentric hypertrophy is nothing but a diastolic heart failure, that is there is no filling of blood. So because of this, the left ventricle size is decreasing but the wall size is increasing. Why the wall size is increasing? Because here the afterload is increasing. So there is a pressure overload. This can be seen in aortic stenosis because the aortic is getting stenosed and that is leading to hypertrophy. Now let us discuss about resistance, pressure, flow. So volume flow rate, if you take this formula, it is flow velocity into cross-sectional area. So resistance is equal to driving pressure by Q, that is A theta viscosity into length by pi r power 4. So if you take it in series, it is R1 plus R2 plus R3. If you take it in parallel, it is R1 by 1 by R1 plus 1 by R2 plus 1 by R3. So actually what this diagram wants to explain us is capillaries have highest total cross-sectional area and lowest flow velocity. So as we said, they're inversely proportional. It is having more cross-sectional area, but as a cross-sectional area is high, there is low flow velocity. Whereas pressure gradient drives flow from high pressure to low pressure. Arterioles account for most of the total peripheral resistance and veins provide most of the blood storage capacity. So what you can understand is arterioles are having most of the total peripheral resistance. So as the total peripheral resistance is high in arterioles, and veins have most of the blood storage capacity. Viscosity depends mostly on hematocrit. Viscosity is increased in hyperproteinemic states like multiple myeloma, polycythemia. Viscosity is decreased in anemia. So delta P is equal to Q into R. Delta P is equal to cardiac output in total peripheral resistance. Now let us discuss the cardiac and vascular function curves. So here the first one, this curve represents the inotropy. So let us understand what is inotropy now. So inotropy is nothing but the change in contractility. As the contractility is changing, there is altering of stroke volume, and that is leading to altered cardiac output, vascular resistance and right atrial pressure. So how to understand this is, first example, we'll say this with example. The first one you can see, this is a catecholamine. So catecholamine, dobutamine, milrinone, digoxin, exercise, all of this will lead to increased inotropy. That is nothing but increased contractility. So automatically, when there is more contractility, there is low total peripheral resistance. So whenever there is any change in contractility, the stroke volume will alter, and as the stroke volume is altered, even the cardiac output will alter, and that will lead to altering even the right atrial pressure. Okay, now coming to the second example, that is about the heart failure. So whenever there is heart failure with reduced ejection fraction, what happens is, you can understand there is decrease in stroke volume. When the stroke volume is decreased, inotropic contractility is also decreased, whereas total peripheral resistance is increased. This is seen with also narcotic overdose and sympathetic system inhibition. Now coming to the second curve, that is the venous return. So in venous return, what they say is, whenever there is change in circulating volume, there will be altered right atrial pressure and altered stroke volume, and that will also alter the cardiac output. So how to understand this with examples? So first, third example, that is a fluid infusion, sympathetic activity and arteriovenous shunt will lead to, you can see this third one, will lead to increase in venous return, increase in total peripheral resistance. So whenever there is increase in venous return, like in the case of fluid infusion, when you give an infusion of fluid, venous return will increase. In sympathetic activity also, venous return will increase. And also in the cases like arteriovenous shunt, that is the blood is coming from the arterial side to venous side. In that case also, the venous tone will increase. As the venous tone is increased, the total peripheral resistance also increase. Next, let us take another example, like in the case of acute hemorrhage, there is loss of volume or loss of venous tone. In the case of spinal anesthesia, also there is loss of volume, venous tone. So here, as the venous tone is decreased, even the total peripheral resistance is decreased. Here you need to understand the total peripheral resistance is directly proportional to venous tone, because it is the resistance which is seen in the blood vessels, right? So this is related to the venous tone. Next, coming to the total peripheral resistance. So changes in total peripheral resistance lead to altered cardiac output, and that will again change the right atrial pressure. So here we'll take the example of vasopressors. So whenever the vasopressors are activated, what happens is, there's increase in total peripheral resistance, but there's decreased contractility because here the total peripheral resistance is high, so the blood heart is unable to contract for this high pressure. Next, in the case of exercise, this example gives in the case of exercise or arteriovenous shunt, what happens is there's decreased total peripheral resistance and increased contractility because you're exercising, your heart rate increases, stroke volume increases, contractility increases, whereas the total peripheral resistance decreases because you are exercising, and there's also shunt. So this is an example of that. So these are the three examples which are showing inotrophy, venous return, and the total peripheral resistance.